Hello and welcome everyone. Today we'll be discussing the four new papers which has been published this week. The first study is on the dexmedetomidine for reducing mortality in patients with septic shock. In this RCT, they included 90 patients with septic shock and heart rate of more than 90. And out of this, 45 received dexmedetomidine at 0.2 to zero point 0.7 microgram per kg per hour for 48 hours, and one group received no dexam, which was open level. Now, the in-hospital mortality was 38% in Dexam and 55% in no dexmedetomidine. But this was not statistically significant. Norepinephrine had reduced need for noradrenaline as well as adrenaline. Uh, but dexmedetomidine did not impact the in-hospital mortality or noradrenaline in patients with septic shock. Though it reduced the need for non-epinephrine, the need for epinephrine infusions. There was also the reduced risk of persistent AF, Apache-2, and C-reactive protein as well as total leukocyte count. So, although this study did not find anything positive in terms of the primary outcome, there were a lot of positive findings in the secondary outcome which can be evaluated in a larger population. The next is the role of EEG guided anesthesia to reduce delirium in older age group patients going for cardiac surgery. So they had a study of around 1140 patients, around 850 men. The median age was 70. Four hospitals in Canada were the source of the patient. So 573 got EEG guided anesthesia, 569 general, the usual care anesthesia. The primary outcome was delirium in the first 5 days, that is day 1 through day 5. The post-operative delirium incidence was strikingly similar, that is 18.15 versus 18.1, and this was not statistically different. So the use of EEG guided anesthesia did not reduce delirium in cardiac patients. The next is plasma as an endothelial rescue in septic shock. This is a randomized phase 2A pilot trial. The background here is septic shock is associated with high morbidity and mortality. Endothelium is a crucial pathophysiological factor in septic shock. Now, currently, whatever therapy we have, they do not actually target the endothelium. So, the study evaluated the efficacy and safety of cell-free, pathogen inactivated pooled plasma for resuscitation in septic patients with the idea that this could probably heal the damaged endothelium. Now, this was a RCT, as we have already said, in a single center in Denmark from 2017 to 2019. The patient aged 18 years and older with septic shock were included. They randomized the patient to receive either of these two therapy, that is RL versus plasma, for resuscitation purposes. The primary endpoints was change in the biomarker for endothelial activation, damage, and microvascular perfusion from baseline to 24 hours. Secondary endpoints were the safety endpoints and mortality over 90 days. The results show that there were 44 participants, and the outcome we were looking for was no significant change in microvascular perfusion or the 5 biomarkers except the VEGFR1. Apart from this change, there was no significant change in using the plasma. So the VEGFR change was higher in plasma group, that was 0.12 versus Ringer's lactate, which was minus 0.24. Now the mean difference for the VEGFR was 0.36, which was statistically significant and favoring the Ringer's acetate. So the conclusion was the plasma did not show significant improvement in the microvascular perfusion or most of the biomarkers compared to Ringer's acetate. So if we look for the future, then probably this particular therapy is not really helping us in either the endothelial prevention or the protection of the endothelium or recovery of the endothelium. Now, again, the change in VEGFR1 was significantly better with Ringer's acetate, which adds to the negative point for plasma. So the final study was immediate or delayed intensive statin therapy in acute cerebral ischemia. This is the INSPIRE trial. This was the RCT. The background here is that acute ischemic stroke or TIA is associated with high recurrence and poor outcomes. So statin is a potential benefit beyond cholesterol lowering, including neuroprotection and improving again the endothelial function. So the objective was to evaluate the safety and efficacy of immediate intensive statin therapy compared with delayed, so that we can prevent these complications. The study design was a double-blind placebo 2 into 2 factorial RCT conducted in two hospitals in China. The enrolled patients were between 35 to 80 years with mild ischemic stroke with NIHSS of less than 5 or high TI risk of TIA, that is ABCD2 score of more than 4 within 72 hours of symptoms onset. Participants were randomly assigned to receive the intensive atorvastatin, that is 80 milligrams daily for the first 21 days, then 40 daily, or a delayed intensive, that is placebo for the first 3 days, then 40 mg daily later on. So the participants were 11,431 patients were assessed. Out of this, 6,100 were enrolled with a median age of 65 with almost 64% men. Now 3,050 were assigned to each treatment group, primary outcome being new stroke within 90 days, poor functional outcomes, moderate to severe bleeding. The results show the incidence of new stroke occurred in 8.1% in the immediate intensive therapy versus 8.4 in the delayed intensive. This was not statistically significant. The functional outcome was poor functional outcomes observed in 9.8% in immediate, 11.4 in the delayed, which was again not statistically significant. The bleeding, moderate to severe bleeding occurred in 0.8 in immediate versus 0.6 in delayed, which was again not statistically significant. So the conclusion here is immediate intensive therapy did not significantly reduce the risk of new stroke within 90 days compared to delayed. The immediate intensive therapy was associated with improved functional outcomes without a significant increase in moderate to severe bleeding. The implications here is the findings suggest that while immediate intensive therapy may not reduce the short-term risk of stroke, it could potentially improve the functional outcomes in patients with acute ischemic stroke or high-risk TIA. Though the benefit, as we saw in this study, was not that clinically important. Thank you for your patience.